My name is Jerry Sherman, and we're going to be discussing an imaging update, specifically on OCT and other fundus imaging devices. As far as disclosures are concerned, I have lectured and have consulted with virtually every company in the ophthalmic industry. Okay, Helmholtz, who is he? Well, here's the guy that invented the ophthalmoscope about 150 years ago. And with spectral-domain OCT and some of our other technologies, we're now learning that most retinal disorders are invisible to ophthalmoscopy in the early stages, but easily detectable with spectral-domain OCT and some other advanced procedures that we're going to speak about. So, spectral-domain OCT and other procedures are rapidly relegating ophthalmoscopy to a much more modest role in diagnosis. Okay. I answered this question already, but let's do it again. True or false? If the retina looks normal with an ophthalmoscope, the retina is normal. The answer is, of course, false, because we said most retinal disease and most optic nerve disease are indeed invisible to ophthalmoscopy in the early stages of the disorder. Talking about OCTs for a moment, commercially available OCTs, these are just some of them. The slide is not brand new, goes back a bit. But we have a whole series of them out there now. We may be up to 8 now, and some companies have 3 or 4 of their own. And you can't buy a bad spectral domain OCT. Every single spectral domain OCT on the market is an incredibly useful device, as we're going to show. And I'm not going to try to pick one over the other. They're all very, very good. We did do a study with one of them. And this was published in a journal called Eye and Brain, the journal Eye and Brain, and it's an open access study, so you can get to it. I was interested in this new screening program, if you will, that OptiView did on their iView system, and it's called the Eye Wellness Exam. And I want to know about the sensitivity and specificity in detecting retinal and optic nerve disorders. When I spoke with the company, they mentioned to me that they actually have never done it, so I sort of said, well, this is something worthwhile doing it. I took some colleagues of mine and we actually did the study using 2 systems that were on loan to us. It went through the SUNY IRB, but we didn't get paid for doing the studies, but they did give us use of the equipment. In any instance, this is one of the results. And as you can see here, we're getting, this is the right eye on that end and the left eye here. We're getting cross sections through the retina. We're also looking at the ganglion cells. And if we look over here on the left, we can see that there are a couple of different problems. One is we're getting some spots in the middle of the retina. These are actually exudates in the outer plexiform layer, very typical of diabetes. And over here are the ganglion cells of the right eye that look pretty normal, but the ganglion cells of the left eye are actually abnormal in that there's a large zone of these that are missing. So this would have been, I would look at this when we did the study, I would know nothing about the patient, just look at the scans and make a determination. Is it normal or is it abnormal? If abnormal, is it a retinal problem, an optic nerve problem, or both? In this instance, I would have said this is a retinal and optic nerve problem. So this patient both has a retinal abnormality, shown up here, and also an optic nerve abnormality. The sensitivity and specificity, when we did it that way, turned out to be above 95%. So it really is a very useful concept of actually screening using OCTs. Not saying you're going to get paid for it, insurance companies won't pay for it, but it is very, very useful. You pick up a lot of pathology that may be missing. When we first started using OCTs, specifically when we went from time domain to spectral domain OCT, we recognized that there was a line deep in the retina, and no one really understood that to any great extent. And we started to call it the PIL, photoreceptor integrity line, after looking at several hundred patients and recognizing how important that line is. When that line is missing under the fovea, the patient doesn't see. Okay, so here's an interesting case. And we can say, does the OCT match the fundus? So the fundus looks pretty good. When we look at this with autofluorescence, we are getting a little bit of an abnormality. This looks like a little bit of an oval, if you will, lesion, and I think you would agree with that. And then if we look at a normal control OCT below, that looks good. The PIL looks like it's intact all the way across. But what's going on over here? Looks like the PIL, the photoreceptor integrity line, is missing right in the fovea. So what does this patient have? This sort of lesion here in the macula, sort of an oval-shaped lesion, and it looks like we're missing the photoreceptors in the macula, and in the macula where the cones are. So this patient happens to be an achromat. This patient has achromatopsia. And of interest, when we first saw this, we recognized it was never published in literature. We put it in Retinal Review, and then a major study was done with the people at Columbia, and this got published, I guess, about a year and a half ago. In any instance, this is not quite pathognomonic. We do see this rarely in other conditions, but it's very common in patients who have achromatopsia. These are patients that are born without functioning cones. And most of the cones, the highest concentration of cones are here. So we're missing that line. The line above it is actually the external membrane that looks certainly thicker in this instance than it's supposed to, and it's probably related to two factors, which I'm not going to go into in any great detail. But clearly the photoreceptors are missing. This occurs not only horizontally, but of course if we take a vertical section, it's going to be about the same, although the horizontal one is a little bit bigger, usually about 800 microns, whereas the vertical is about 600 microns in size in these achromats. Okay, how about this case? We're looking at a retina and a vitreous. This looks like the vitreous tugging on the macula, so we can call this evitreal macular traction, if you will. This patient may have 20/20 visual acuity. The issue is, do you want to do anything about it? Jetria is a product out there now that can be injected into the vitreous to try to break the bond between the vitreous and the macula, and in some cases that's probably indicated. Here's another interesting case where we have something going on in the vitreous. Here we have blood vessels growing from the retina into the vitreous, and this can happen very commonly in a condition like diabetes, diabetic retinopathy, proliferative diabetic retinopathy, but can occur in a lot of other disorders as well. Here's another diabetic patient, or a diabetic patient, and although with an ophthalmoscope you may see nothing that's abnormal, this patient does have some cystic spaces in the retina. This patient does have a little bit of an epiretinal membrane, as we can see over here. But this is really interesting. These are two scans using two different devices. These are new blood vessels growing from the retina into the vitreous. Now, these are invisible to ophthalmoscopy. So just on a basis of this patient actually has proliferative diabetic retinopathy, and with an ophthalmoscope, this patient would look completely normal. The patient did look completely normal with standard ophthalmoscopy. And yet there are some macular changes and changes on the surface of the retina, in addition to new vessels. And these are fragile vessels growing into the vitreous, so these can certainly bleed, causing vitreal hemorrhage. Here's an interesting patient. It's an ultra-wide field image that has been blown up a little bit. You can see the patient has some macular drusen. We see a large lesion here, but internally we see some circles. Actually, it turns out there are 5 of these circles, which are within the larger lesion. And you might say, well, what's actually happening here? Well, we can do a vertical OCT out in the periphery and notice that when we look above this horizontal blue dotted line, we can see that there's an inner retina that's intact, and we're missing what looks to be an outer retina, no outer retina. If we look below the blue dotted line down here, it looks like we have an inner retina and an outer retina, and there seems to be in a sense, a space between those two, and this would be called a retinal schisis. So this is actually a retinal schisis, a split within the retina from the inner, the inner retina is separated from the outer retina. Above, we still have a retinal schisis, but in addition, this is actually a hole. We have the inner retina intact, but the outer retina is missing. So we would define this as an outer retinal hole. This patient has 5 outer retinal holes within a large area of retinal schisis. And OCT is extremely useful to give us some sense of what's actually going on anatomically and how to treat the patient. Here's another patient where OCT is very, very useful. This actually goes back a while. And we can see here that we have 2 cross sections. And the cross section going through this lesion here, one of those is right over here. And this actually looks like, if you think about it, the retinal pigment epithelium is here below. We have the sort of a thin retina here. But if we look at where the retinal pigment epithelium meets the retina, we can see it looks like the retina is being tugged apart. So this bottom one actually corresponds to a retinal schisis. Above, we have this, a horizontal section going right across here. And here we have the retinal pigment epithelium, and what looks like the rest of the retina, the 9 layers of the neurosensory retina, separated from the RPE. So this is actually a true retinal detachment. So this patient developed a retinal schisis. You can see this is thinner. This section here is much thinner than this, but it's only part of the retina. This is the entire retina. Here's a retinal schisis that led to a retinal detachment, which probably occurs in about 1 in every 300 cases or so. How about this image? What's going on here? Well, it's a cross-section, it's a vertical section, and that's what it looks like with an ophthalmoscope or with a fundus camera. And we can see that we have some heme right over here. And this is a hyaloid space, subhyaloid hemorrhage. And notice over here, these are little tiny dots. These are red blood cells that are actually, because of gravity, are accumulating down over here. So here's what it looks like if we looked at it with a 30-degree fundus image. So that's that hemorrhage. This is blown up, and here's the OCT of it. So you can see it's actually a subhyaloid hemorrhage. This is being the hyaloid. Very interesting to get OCTs of a lot of these types of lesions. How about this one? What's happening here? Well, we see some circles, so we have a sense of what these circles are. Well, here's what the fundus looked like, and this slice is right about over here. We're going right through this lesion over here. So is that anything? Well, is it related to a blood vessel? It actually is. This is actually an artery that's actually has been dilated. So this is like an aneurysm of an artery. So this is a macroaneurysm, as labeled. All of these kinds of all these specific images that we just went through are on Retina Revealed. Retina Revealed is a free website, which is available at www.retinarevealed.com, and up to about 3,000 images in hundreds of cases if you go to Archive and look under Archive. Okay, let's go a little bit more advanced. All those are interesting, but nothing really that new. But we do have a new way of looking at blood vessels, and this we call OCT angiography. It's using OCT. It's not using an injection, but by taking multiple images with more advanced systems, we can actually look at blood vessels, which I think is somewhat remarkable. So OCT angiography is a new imaging modality that gives us a lot of additional information about blood vessels themselves. And it is non-invasive. We're not injecting sodium fluorescein into an antecubital vein. One of the systems that does it is the Avante, actually perhaps the only system that does it at the present time. This is an OptiView system. This is the Avante. And we're looking at a cross-section of a specific patient. These images are not the standard 6 by 6 millimeters, but are actually 12 millimeters by 9. So we're getting to look at more of the retina. On FOSS OCT, which is sort of like a fundus camera, if you will, looking in the face of the patient, we can actually do this. It's an OCT, it's on FOSS OCT, and there's no injection. We can actually see the blood vessels. So here we're looking at superficial capillaries around the avascular and macula. Below that, we're looking at deep capillaries over here. And here is the outer retina. And the outer retina in this specific normal individual looks okay. And here we can actually look at the choroidalis as well. So we can get these 4 different sort of on FOSS images at different levels. And we're actually looking at a normal retinal anatomy in this instance. We can also do it with a 3 by 3 millimeter zone or 6 by 6. 6 by 6 we're seeing more retina, and the avascular zone of the fovea is going to look smaller, as it does over here on the right. This allows us, this technology, OCT angiography, allows us to look at the optic nerve heads in great detail. And here we can see the optic nerve head and all the blood vessels on the surface and the capillaries on the optic nerve head. So this technology without injection is going to be extremely useful to show abnormalities of the optic nerve itself. The chances are, and some of this has been presented from people who have the system in places outside the United States where it is available at the present time. The system itself is available in the US at the present time, the Avante, but the software hasn't been approved. So the software specifically for the OCT-A, the angiography, is not yet available, but will be. The point is, we can see vessels on the surface of the disc. This is going to be very useful in assessing patients who have glaucoma and non-glaucomatous optic neuropathies, or who are at risk of those kinds of conditions. Let's go back to looking at the 4 scans that we looked at before, and we talked about the superficial and the deep. Let's take a look at a patient that actually does have choroidal neovascularization. So the superficial scan doesn't look very much different. The deep scan doesn't look very much different. But when we get to the outer retina, we can see, without doubt, new blood vessels forming. And these blood vessels also show up at the level of the choriocapillaris. So these on-FOSS OCTs are, in a sense, the Angioflow images, but they're really without without any injections. The same system that we're talking about does these kinds of images, is available through OptiView, again the Avante, and you can see this is actually a 12 millimeter scan, and we're getting a sense, 12 by 9, they're getting a sense of the detail that we can actually get. So we're seeing the macula and the optic nerve head in dramatic detail. We can look at the choroid over here. These are this cross-section of the larger choroidal vessels and Howard and Sattler's vessel layer. We don't see on these cross-sections the choroid capillaris was still too small, but we can see Howard and Sattler's layer. So these are cross-sections of Howard and Sattler's layer, the big blood vessels in the choroid. We can also see where the sclera begins, where the choroid ends and the sclera begins, about over here and maybe about over here. In addition, look at the vitreous. We're seeing details of the vitreous that we've never had access to prior to this type of technology. This is a 12 millimeter scan. Okay, and here's another. This one is actually labeled as a 13 millimeter scan. And again, you can see the vitreous in great detail and how it relates to the retina. Here's the foveal pit. Here's the so-called PIL, photoreceptor integrity line, which is right over there, and the external membrane above it. Very interesting, all the detail that's possible with this new technology. I believe this is using 70,000 A scans per second. Most of the systems that we use nowadays are using 27, 28, or 29,000 A scans per second. Evolution of OCT. Time domain was only using about 400. The newer systems, the spectrum domain, we're using going to about 2,700. We can go to about 70,000 with the one that we just spoke about. And there's actually some systems out there using a swept source that do about 100,000 A scans per second. The fact that you're doing more scans per second doesn't mean that you're going to get better images, but it certainly does, giving more scans. As a general rule, there's a relationship between the number of scans we're getting per second and the resolution of the scan. So this is actually done with, I believe, the Topcon system, high-resolution B-scan, and we get this deeper penetration that we already spoke about previously. This is a right eye. The disc is over here. This is the retinal neurofibromatosis layer. As you can see, here's the foveal pit. This is the PIL, photoreceptor integrity line. Above that's the external lumen membrane. And you can see the choroid, as we talked about before, with cross-sections through the large choroidal vessels. And here's the position of the sclera. So the detail is much greater than anything we've seen in the past. This detail is as good as what we've seen out of anatomy textbooks in the past. So this is in vivo. We're doing this in real patients. Okay. Here we're looking at the vitreous, some subtle attachments of the vitreous onto the optic nerve head. We can see choroidal vessels here. And again, retinal neurofibromatosis layer shown right over here, and here's the foveal pit. This will also allow us to start to look at the lamina cribrosa sclera, and that may be very useful when we're thinking in terms of glaucoma suspects and glaucoma patients. This system also allows us to do some automated 7-layer segmentation, as shown on this slide. And just going back for a couple of moments, I didn't make these, but these were made available to me, illustrations of time domain. In time domain, we actually moved a mirror. You can see the mirror moving up here, the reference mirror, and then we had a detector. So this is about, we talked about before, how many scans are we getting here? And we're seeing about 400 A scans per second with time domain. Then we went beyond time domain and went to spectral domain. When we went to spectral domain, we had a fixed mirror, didn't move, and we used a spectrometer over here. And again, these are capable of giving dramatic images when we start to use more of these scans per second, such as the ones we showed before with 700 A scans per second. We can also go to the swept source, which is a little bit different. And in the swept source, we're actually using a sort of a tunable laser. Okay, and that's going to give us these also these very nice images. There is a difference between the time domain and the spectral domain. And the spectral domain now has some great images that we can get, and now the swept source is something which is also I think going to be available shortly. We do get some uniform sensitivity, vitreous, choroid, and lamina cribrosa in one scan. This is, I think, a 12 millimeter scan by 9. So we're seeing lots of retina in a single scan, and it's all in very good resolution. Here's the vitreous. So lots of things going on in the vitreous that we've never seen previously. And another example of some intraretinal cysts that we can get, some exudates, and some other areas in the vitreous. Those who like the vitreous are going to see details of the vitreous that we've never seen in the past. Yes, we were able to see posterior hyaloid in the past, but not the extent that we're seeing over here. We have some names that you probably have never heard of, areas that are being named for the first time, or for times that we, most clinicians haven't had experience with. Okay, let's switch gears for a moment and go to another technology. This one is out of Canada. The name of the company is Anidis. It's called the Multi-Spectral Imaging device. And it's like a fundus camera. I believe the standard scans 43.5 degrees. And if we look at the human photopic luminosity curve shown over here, the human eye is most sensitive to light at about 555. Okay? Fundus photography, shown below, is meant to mimic what we can see with the human eye. This technology looks at things a little bit differently. Rather than taking one picture as a fundus photo does, we're taking 10 images, each one with a different LED, light emitting diode. Each one penetrates to a different retina, to a different layer of the retina and to the choroid. So green is about over here, here's yellow, here's amber. Then we get into the red and the red 1, red 2, red 3, and into the infrared. This is a patient of mine. This has been published in a couple of places, not to mention in ophthalmologic journals. And what's interesting here is with a direct ophthalmoscope or with an indirect ophthalmoscope, this patient looks normal. However, when we use the Anita system and we look at the green, yellow, and amber, those look okay. But as soon as we get into the red and the higher reds, the red 2, red 3, and red 4, and into the infrared, we're starting to see lesions, dozens of lesions at the level of the choroid. So right over here are the reds, which are almost invisible to the human eye, but certainly the infrared by definition are all invisible out over here. So we're seeing things that are invisible to ophthalmoscopy, invisible to standard photography, that show up really, really well on this Anita's multi-spectral imaging device. Again, another way of thinking about it is here. We're looking at the retina, the inner retina and the outer retina, the green, the amber, and the yellow, forgetting about the colors, well, they're sort of matched up. And the red one, we talked about the red is penetrating deeper. This blue one is really meant to be the infrared that penetrates the deepest. So by using these different LEDs, each LED is a different color. Each color LED penetrates to a different zone of the retina or the choroid. And by doing them all together, we're getting these remarkable images going from the retina, going all the way back into the choroid. This case is the one we published with neurofibromatosis, a very interesting patient. Don't see anything clinically. The TopCon image looks pretty normal. Optos was able to pick it up because Optos is actually using a red and green laser together. And if you're using the red laser, which Optos does automatically, the red laser is able to image some of these lesions in the choroid. If we then look at the MSI, the multi-spectral imaging device, the Anita's device, we have this color composite shown over here. We have the green that looks okay, but as soon as we get into the red and the infrared, we're seeing a dramatic number of lesions that were completely invisible to ophthalmoscopy, both direct and indirect ophthalmoscopy. Here's the left eye. We're seeing the same kind of thing. The colon composite looks okay. That's the composite of the green and the red 1. But when we get into the red 2, red 3, red 4, and the infrareds, we're seeing dozens of lesions that are invisible to ophthalmoscopy. This patient does have an abnormality. This is called neurofibromatosis. We don't have that much evidence on it now, but it looks like other patients with neurofibromatosis have similar lesions. The standard OCT actually looks normal in these cases. I can't tell you what an OCT that would penetrate into the choroid would look like, if that would be abnormal or normal, based upon the two that we just spoke about, the more advanced OCT images. But the standard OCT was completely normal. When we asked the patient about these spots in the retina, she says, well, no one's ever picked them up before. We can discuss with the patient any spots on the skin, and sure enough, she had a whole bunch. Here's one over here that was invisible to me initially, but she pulled her sweater back, and sure enough, this is a pigment spot in a sense, sort of a cafe au lait spot. Okay, not elevated. Here's her belly button, and she has hundreds of these lesions on her body, actually thousands, just giving you a sense over here. And some of these are elevated. The elevated ones are actually neurofibromas. So the subcutaneous neurofibromas, little tumors. The ones that aren't elevated, many of the ones that aren't elevated are just these cafe au lait spots, if you will. And these are both typical of neurofibromatosis 1. This patient is 27 years of age, and it turns out that she's going to live 10 or 15 years less than her friends because of lesions like this that would be growing in her brain. Lots of research being done, lots of different drugs being tested to try to slow down the progression of these, not only on the skin, which are more cosmetic than anything else, but certainly the ones in the brain that could lead to problems and death, early death. The same technology can be used to look at retinal images. Kerry Gelb was the first to actually pick this up. And the MSI, he found yellow was very good to pick up abnormalities associated with diabetes. And he called these sort of related to insulin resistance more than anything else. And these little tiny lesions or capillary dilations can be picked up on the yellow and are easily missed on others. So Kerry may have brought something to our attention, a really easy way or a way of diagnosing really early diabetes, even before the hemoglobin A1C is abnormal. These patients that have these lesions that we're seeing over here appear to have abnormalities in insulin resistance, as shown over here. So these outpouchings, or just capillary dilations, can be picked up with the MSI device. And here's some other examples of those. These outpouchings. Again, you're going to see more research about this published. I don't think any of this has been published yet, so this is stuff that we're borrowing from Kerry. I've looked at some patients of mine with these, and I think Kerry's correct that we are getting these sort of outpouchings or capillary dilations in a bunch of these patients. Okay, the same device could, or the more advanced a device of this type can look at lots of different things. It can look at inverted choroidal images, allowing us to look at the choroid in great detail. It allows us to actually look at the anterior segment of the eye as well, and get some beautiful views of geographic atrophy. Something that this newer device, the newest version of these devices does, or it's called transchoroidal imaging, TCI. And how does it work? Well, we're using infrared light, and the infrared LED is actually introducing light around the eye, not through the pupil, which is traditional, of course, with all fundus imaging, but we're introducing infrared light around the eye and through an LED, and then we wind up with these rather remarkable images of the choroid, kinds of images we've never seen before. So there are technologies now that are going to allow us to look at the choroid. The choroid has been pretty much invisible to us for many, many years with standard ophthalmoscopy and standard other procedures. Another very interesting area that's being developed, this is not available yet clinically to my knowledge, but is available from our, using some research instruments that are out there, and it relates to predicting Alzheimer's disease from the eye. Many of us have heard the term beta amyloid, and beta amyloid is considered to be the biomarker for Alzheimer's disease in the brain. But we know that beta amyloid exists not only in the brain of Alzheimer's patients, but also exists in patients with AMD and in the eye of patients with Alzheimer's. So beta amyloid, the major extracellular deposit of Alzheimer's disease, we get these plaques, but we've also found them recently, not us, but some researchers found this recently in AMD drusen. So patients who have drusen can have beta amyloid within the drusen itself. Looking at beta amyloid in 9 patients with AMD, or looking at patients with AMD, 9 eyes, 4 of the 9 actually had beta amyloid, which is pretty remarkable. And they're most numerous in the patients who had geographic atrophy, near the edges of the atrophy. And none of the 9 normal eyes that were tested had beta amyloid. So we think that there's some way, there are different mechanisms of looking at the retina to give us information about the presence of beta amyloid, which would really be the presence of probably systemic Alzheimer's disease. We can look over here at beta amyloid in patients with drusen. We can see a bunch that have it, but in the normal controls, we're getting none, as we're showing over here. So this seems to work. If we look at the brain of patients with this disorder, what do we have? We're looking at these beta amyloid plaques, okay, in these patients with Alzheimer's disease. Going forward, here we're looking at a patient who has drusen, and these drusen are right next to areas of geographic atrophy. And within the drusen, we're actually seeing what we think are the same, beta amyloid deposits. So the eye may actually hold the answer for the methods of early detection of Alzheimer's disease. Neurologists are frustrated because MRIs are not very good in early stages. The eye is probably a better place to image these beta amyloid deposits, and there's a lot of research in order to trying to perfect that. This image is from a company called Neurovision. This is not available commercially at the present time, but we can see these beta amyloid deposits within the eye. It's sort of somewhat amazing. And here we're indicating this, there's an index that this company actually creates. And we think it does correlate with amyloid in the brain. So this may be the newest way of diagnosing Alzheimer's disease by looking, using advanced sophisticated procedures for looking at beta amyloid deposits in the retina. Of interest, I probably should mention something about this. How do we get these? How do you actually take the images? Well, if you have curry, if you like curry, and curry has some things in it that like curcumin, which seems to be a fluorochrome, which has an affinity for these beta amyloid deposits. So if you eat a meal or take a pill, and these pills have curcumin in it, and you then hours later image the patient, it turns out that the curcumin has this affinity for the beta amyloid deposits, and then they fluoresce. So there's sort of fluorescent properties, and these fluorescent properties can be detected with various devices. So identification of amyloid plaques in the retinas of Alzheimer's patients, and this is non-invasive. We can also find them in a mouse model. So this is something that will probably be in our future. How about early plaquenil toxicity? Well, we know that we can pick up lots of things in the eye associated with plaquenil toxicity. Most of these patients may have 20/20 acuity at early stages, but then we get sort of these rings around the macula. And those are sometimes easy to pick up and sometimes a little bit more difficult to pick up. With OCT technology, usually the PIL becomes involved initially, not under the fovea. It's usually pretty intact under the fovea. But we start to lose, interesting enough, in the very, very early phases. The PIL may be relatively intact, but we lose the area that sometimes some authors have called Verhoef's membrane, which has been renamed a few times, sort of like part of, if you will, the retinal pigment epithelium. And Verhoef's membrane in normals is here. It starts to disappear in these areas over here, right around the macula. We have one of these cases of a little bit more advanced loss in retina revealed. I think it's retina revealed number 2. Okay, let's go to a different technology. How about fundus autofluorescence? Fundus autofluorescence is remarkable for its ability to show us abnormalities at the level of the retinal pigment epithelium. And every time the RPE dies, the photoreceptors die along with it. At least we think that's the case. Although there's a higher correlation between death with rods and innards with cones. But even with cones, there seems to be a pretty high correlation between the abnormalities of the retinal pigment epithelium. So here's the left eye of a patient. Here's the disc, if you will. Here's the macula. This patient still has relatively good acuity. This black area here corresponds to hypoautofluorescence. Hypo meaning that we're getting too little of the autofluorescence. Normal fluorescent pattern would be, say, about over here or over here. When we start to get the really dark zones, the hypoautofluorescence, the retinal pigment epithelium is dead. Often, as we can see here, when we have those zones, we have hyper right around it. So we sort of have a border of hyperautofluorescence, which says that the retinal pigment epithelium is not dead, but it's metabolically active and sick, if you will. And if we can't do anything about the condition, the chances are that black zone is going to increase and that white zone is going to be replaced by black. There may be a new white zone, which it will then form right outside of that. So this patient has this fascinating image. And of course, I can ask this patient to turn their head by 90 degrees to try to make this into a question mark. But you could just, rather than doing that, you can just turn the picture by 90 degrees and actually get this. So what is autofluorescence all about? Well, autofluorescence is related, to the pigment that we find usually in the retinal pigment epithelium. And this pigment called lipofusin is very, very important. It builds up in the retinal pigment epithelium and it's hyper. And then when the RP dies, it actually somewhat disappears and we wind up with these dark zones. So we can use the knowledge of this in many, many ways for lots of different conditions. Here's a color image, just actually an optos image blown up, an ultra-wide image blown up of patients of a patient with geographic atrophy of the retinal pigment epithelium. Here we're seeing drusen. There's some choroidal vessels under here that we can see because the RP is missing. Geographic atrophy of the retinal pigment epithelium, if you will. Here's an autofluorescence of that same patient, and we can see since the RP was missing, we thought here, it would make sense that we get this dark zone. This looks like my left foot, my big toe right over here, I think, and this will actually increase over time. Lots of different research out there, about 12 different drugs that are being tested to see if we can actually stop the progression of geographic atrophy. I'm told that some of these drugs may actually get approved in the next couple of years, and maybe we'll be able to halt the progression of this condition. Of particular interest here is the fact that drusen showing up here do not correlate directly with the areas of dead RPE. So the hypoautofluorescent zones do not correlate with the drusen. You can't predict what we're getting here, which is death of retinal pigment epithelium, from just the view of the drusen by themselves. So clearly we're getting some additional information with this new technology. This slide we actually showed in a different lecture as well. It's a patient with some drusen, maybe a dozen in the posterior pole. And if we look at it with ultra-wide field autofluorescence, you don't see just the dozen drusen in the posterior pole. We see maybe 150 of these hyper autofluorescent spots, and maybe a couple of dozen of dark spots as well. So we're getting a lot more information from the autofluorescent image than we are from the color image. And this patient of interest happened to have Alzheimer's disease. So is there a relationship? Because we talked about the special technologies that exist to pick up beta amyloid in the retinal pigment epithelium. It's possible that some of these patients who have these kinds of appearances may also have Alzheimer's disease, but that remains to be seen. Certainly more research is needed. Here's a patient that converted from dry mactogen to wet mactogen. The dry mactogen in the left eye is still present with 20/20 acuity. The right eye has dropped to about 2100, and it's just a large scar. This over here could actually be a fold, or an RP rip, if you will, and it's folded on itself, that hyper autofluorescent pattern. Okay, let's take another condition, Azor, acute zonal occult retinopathy. Here's a 69-year-old female with a 30-year history of some strange photopsias in the right eye, but now recently in the left eye. Here's her left eye. The left eye in this ultra-wide field image looks pretty good. There's not much going on. We see some lashes perhaps, but also some choroidal spokes because the patient does have cataracts. Here's the autofluorescent image. Amazingly, there's a zone that was not really well visible at all, but here you can see this dark zone with some white spots within it, and also maybe surrounded by some hyper autofluorescent areas. Here's the disc with a subtle hypo-autofluorescent ring around it. But let's look what happened in a mere 8 weeks. This turned into this. So this was an active condition. It's ongoing now. Patient has symptoms, vague blurred vision and vague photopsias. And again, the color image on the upper left doesn't give us justice as to what's going on down here with the death of the retinal pigment epithelium. And again, we sort of have this ring around it of hyperautofluorescence around the hypo zone. So this is actually still increasing, as we can see. This is about 8 weeks apart. So this is when the patient came in with complaints. We saw this. Patient was not treated. There are some treatments that may be instituted in this condition, Azor, acute zonal occult retinopathy. But at this point, Imuran was not used, and it's still being considered. We can see there's a clear growth of the abnormality over a period of 8 weeks, and we're getting closer and closer and closer to the center of the fovea. So this patient has been seen by some rheumatologists, and we are considering using Imuran because this is thought to be an autoimmune disorder. Look at that dramatic change in a relatively short period of time. So autofluorescence gave us information that really wasn't available to standard color imaging. We also looked at this patient with fluorescent angiography. This is with an injection, and in a period of 6 weeks, this patient also changed dramatically. So both of these were very useful to show the dramatic advancement in a relatively short period of time in this patient. Now, patients with Azor, this is acute zonal occult retinopathy, which means it's acute onset. It could be occult, which means invisible to ophthalmoscopy. The Z stands for, the A is acute, the Z is for zone, certain zones of the retina. You can see certain zones of the retina are affected here. AZ, the O, the first O is for occult. It's sort of occult or not visible to ophthalmoscopy. And the OR, AZOOR, the OR stands for outer retina. So it's affecting the outer retina being the retinal pigment epithelium and the photoreceptors. Again, those same dramatic images. Okay, another case is a fascinating one of a patient with a retinal degeneration, but we first saw this patient. The patient was referred, and we didn't know that. It's a 45-year-old female, and she was a myope, about a 5 diopter myope or so. and she was complaining about some night vision problems, and her basic exam was okay. And what we usually recommend on these cases, if you have somebody with a normal fundus appearance and they're just complaining about night vision issues, you can just give arbitrarily some extra minus at night, see if it helps for empty field myopia, or, I guess what we call empty field myopia, which is, we do find at night it being a little bit greater. Patient just needs a little bit of extra minus. However, in this instance, it was a little bit different. So that was already tried. The patient said, yes, the new glasses for driving seem to help a little bit, but I'm still plagued. I still think there's a problem. So here's what the ultra-wide field image looks like. And we're not really seeing much going on around the disc or the macula. In the far periphery, we're seeing this. We can call this paving stone. Looks like a form of paving stone degeneration. Patient is over the age of 40. Patient is over 4 diopters of myopia. So the patient has about a 50% chance of having paving stone, which is very common in older patients who are myopes. Here's the left eye. We're seeing pretty much the same type of finding. Of interest is the next image. What's going on here? What's going on here? Well, this was invisible to ophthalmoscopy. This is a zone of hyperautofluorescence, which means the retinal pigment epithelial cells are now, if you will, metabolically active and sick. They haven't died yet because we're not getting any dark zones. But if you look at the far periphery, we did get some death of the retinal pigment epithelium. And this zone over here strongly suggests that this is progressing. So this is sick RPE, and this is sick RPE, so this is going to continue to progress. This patient has a form of retinitis pigmentosa. It's a little bit unusual in that it's virtually invisible to ophthalmoscopy, but easily visible with autofluorescence, which is a great technology for this. And here we go, looking at the symmetry of the right and left eye. Most retinal degenerations, like RP and Stargardt's disease, are very, very symmetric. So here is showing the kind of symmetry which we'd expect. Again, the central lesions were invisible to ophthalmoscopy, as were the peripheral lesions, which are hyperautofluorescence. The only ones we saw were the hypoautofluorescence zones over here with the standard ophthalmoscopy. One more look over here for the comparison. Okay. We also have lots of other conditions where this technology, here's an OCT technology, looking at the disc, which is something most people don't bother doing. But if you take high myops and you look at the disc, you're going to see retinal schisis, splits of the retina around the optic nerve head. In a lot of these patients, this is not particularly rare. I think I've seen 27 of these that we've documented over the last couple of years. So this is not at all unusual. Here's the patient, right eye and left eye, and we can see that in the right eye, it seems to be the splits are nasal to the disc, and here's the left eye. The split is also nasal to the disc. Okay, so this occurs more often nasally than temporally. We can see it in both eyes here, and we can see it in color as well as in grayscale. And this can lead to a retinal detachment. Some of these splits in the retina and these high myops are due to traction of the vitreous onto the retina. And we have a couple of cases like that. We can actually see the traction. So these patients, all high myops, I think, should be scanned. Their macula should be scanned. Their discs should be scanned. Of course, they should be looked at with a binocular and direct to look at the far peripheral retina for holes and tears. But this is another cause of acuity reduction in field loss in high myops. These splits in the retinas that sometimes lead to retinal detachment. So we have seen that. Here's another case. This is a youngster, and this patient is like 8 years of age, presented with acuities about 2200. Fundus really looks pretty normal. These are just reflections off the internal living membrane. But when we look at autofluorescence, we're clearly seeing an abnormality. The normal fluorescence is out here or here. The macula is darker than it should be, the oval macula, if you will. Then we have the hyperautofluorescent zones here, and the specific little spots, which are really not really round, they're more fishtail. These are fundus flavi spots. So this looks very typical of what we'd expect in Stargardt disease with fundus flavi maculatus. And it should be symmetric. As we can see here, it's quite symmetric. Stargardt disease with fundus flavi. Of interest, it was essentially invisible to ophthalmoscopy, but very, very visible with the autofluorescent images. And if we look at OCT of the same patient, comparing a normal to this patient, we can see the whole outer retina is missing. The PIL shows up over here, the external membrane above it, very thin, but both of those layers are missing in this patient. And that's in both eyes. So there's an 8-year-old with acuity of about 2200 with a fairly normal basic exam seen by a lot of different doctors. Everybody said the retina was okay, but both autofluorescence and OCT picked up the diagnosis. Of particular interest, his two sisters were with him on this referral, and I asked Mom for permission to looking at the kids. So here's a 5-year-old. She has lots of reflections off her internal wing membrane, normal for a 5-year-old. Good acuities. Acuities are actually best correctable to 20/25 where we pushed her. Here's her images with autofluorescence. And you can see we do have sort of a bullseye maculopathy, fairly symmetric bullseye maculopathy in both eyes, which has been reported in early Stargardt's disease. It can also be in plaquenil toxicity and accutane toxicity and cone dystrophies. In this instance, we're pretty sure that this is in the same family of this patient with Stargardt's. Let's look at this patient's OCT. Of interest, it looks completely different than a normal. The difference being usually the elm, the external wing membrane, is very, very thin. We don't see. But in this instance, the elm, the external wing membrane, is incredibly thickened. Now, the brother didn't have that because he lost that tissue already. So the 5-year-old and the 4-year-old have this external, thickened external wing membrane. The brother doesn't have it, and the brother doesn't have a PIL as well. So these are sort of, it's a transient biomarker for early disease. Here's the 4-year-old. And the 4-year-old maybe has an abnormality on autofluorescence. We're not really certain. But clearly there is a clear abnormality here on the OCT, as we can see. Again, the thickened external wing membrane. And the PIL, which is in purple, is a little bit thinner than it's supposed to be. But usually the external membrane is about 5 to 10 times as thick and as hyperreflectors as the PIL. And here the ratio is opposite. Here the external membrane is much more obvious than is the photoreceptor integrity line. Again, looking at a normal compared to this 5-year-old, and we can see a definite pattern. So whenever you're learning how to use OCTs, or even when you have a difficult case, always look at a normal and compare a normal to the abnormal, and then you can sort of figure out what layer is abnormal with what's actually going on. And that's what we did in this instance. And we think that this condition might be due to photoreceptor degeneration, which actually results in debris accumulating on the external wing membrane. But that's just a hint. We're not really sure. The point is we're fairly certain we've actually seen it being sort of transient. It does disappear, but there are times when you might be able to diagnose Stargardt's in a 4-year-old and a 5-year-old, as we did, but maybe even in a 3-year-old or even earlier than that. Sort of like this debris sticking to the external wing membrane as we have leaves sticking to a fence. So that may be why it's thickened, but we're not sure. Another condition that we see frequently, actually, on referral, a patient has a PIL present centrally, but not peripherally. So here's the PIL present under the macula, but then as we look out to the periphery, the normal's below, the PIL is still present, but in this patient, it's not present. So the retinal pigment epithelium is present, but the PIL outside here is not. That's outside of the macula. So if you remember, the macula is where the highest concentration of cones are. We get to a point where the cones are in very low concentration and the rods are in very high concentration. So in this instance, we're looking at a rod abnormality. So this patient has a form of retinitis pigmentosa. Treatment does exist. So at least some treatment has been shown by some studies to maybe help a little bit. Vitamin A, and we have to avoid high levels of vitamin E. It's from an old study, but it's probably accurate. Omega-3s may help. Trusop may help, as you'll see in a moment, and Diamox also may help. Anti-VEGF injections have also shown to help in some cases. Here's a 7-year-old female with Usher syndrome, which is retinitis pigmentosa plus deafness. Notice her very thickened macula. She has a form of cystoid macular edema. And there she is with Usher syndrome and real Usher signing. Here's a patient of mine who has Usher syndrome, but not a little girl. This is a male, about 37, 6'9", does not play basketball. Does have retinitis pigmentosa, does have some cystic spaces, as we can see here, with 20/30 acuity. Here he is with 20/30 acuity. Then his acuity dropped to 20/50 in both eyes. And he came in with much larger cystic changes. We told him, let's try carbonic anhydrase inhibitors, first eye drops like Trusop. That didn't work, we don't think. Then we put him on Diamox along with the Trusop. And after we put him on Diamox, his acuity went from 20/50 to 20/20 in this eye, this is the right eye, but also in both. And the cystic changes pretty much disappeared. Then he stopped taking his medicines because of, a storm. He couldn't get to his meds in Lower Manhattan, Superstorm Sandy, actually, and it came back. So it turns out that it seems like the Diamox was able to inhibit, or sort of dry out this whole area. And we have the same findings in the other eye. We have cystic changes here with 20/30 acuity, 20/30 acuity, dropped to 20/50, treated with Diamox, and he improved significantly. Got worse when we stopped the Diamox, when he stopped the Diamox. Okay, so we thought Diamox worked, and we asked him how long did it take the Diamox to be effective. He said, on the 4th day, I saw a change in my vision, which is pretty dramatic. We also have fluorescein angiography of the far peripheral retina. Here's a patient with a lesion in the far periphery. We can do fluorescein. This is true fluorescein with injection. And by doing that, we're actually seeing the vessels themselves. So this patient has sarcoid. And you can see new blood vessels growing on the surface of the retina. And you can see areas where there are no capillaries whatsoever, avascularity. Pretty remarkable. We can also look at this over time. Initial stage, 12 seconds afterwards, 50 seconds afterwards. So the concept of being able to do fluorescein angiography, the entire fundus, I think is remarkably useful for a lot of different disorders. Here it's useful for a form of Coates disease. And of interest, Coates disease doesn't affect the nasal retina, we don't think. It affects the temporal retina, usually in young males in the first decade of life, but we can look at the fine vessels that we can see in the far periphery of the right eye. So these capillaries are about 7 microns in size, and we can view them easily. This is one image. All we have to do is blow up that image and look at the fine capillaries. So this technology allows us to look at the vascular tree in exquisite detail, but at the entire vascular tree at once. One other technology we're going to end with, retinal function imaging from optical imaging. This is a technology where we're looking for sort of blood flow and blood volume. And they take multiple images, do a subtraction procedure, and we can actually see change over time, which you'll see here. It's pretty remarkable. So what they're really doing, let's take 8 sequential images, taking them just separated by milliseconds. What's changing in the blood vessels in just a few milliseconds? The only thing that's changing are the red blood cells. So as the red blood cells move, we can actually show the change of the position of the red blood cells in frame 1 versus frame 2. And this is what we're left with. We're left with imaging of the actual vessels where the red blood cells are just moving. So there's a lot of new technologies out there, and these are all blood vessels. These are red blood cells moving within the blood vessels themselves. So this technology is now available to us. So just in summary, lots of things are out there. We could look at maculas. We looked at this in detail before. We talked about the OCT, but we have another way of doing it non-invasively, which was with this technology, the optical imaging folks. We can see these very, very fine vessels in exquisite detail. Okay, looking at discs, we can look at discs if there are any vessels missing on the surface of the discs. So another very promising technology. Okay, I am out of time, and I hope you've learned something. Thank you very much.